Well, guys, continuing with the pulmonology physiology, the lecture today is about the lung compliance, chest wall compliance, and then the compliance of these two together. The topics that we'll cover are, number one, we'll see the formula for the compliance. Then we'll see the properties of the compliance. What do we mean by compliance? Then we'll see the lung, chest wall, and combined compliance. And finally, we'll see a couple of pathological conditions where compliance changes. We'll see emphysema and fibrosis and see what happens to the compliance. With this, look, I got some fun stuff today to do. I got some grapes here. They are going to represent our alveoli. I have this red bag, if you can see. This bag is going to represent the chest wall or chest cavity. And then I've gotten some balloons as well. So I get to play today with this lecture. So these balloons are going to represent lungs and the alveoli. Cool. So let's talk about the compliance. First of all, definition and the formula of the compliance. The formula is this: compliance equals the volume change for given pressure change, or it is the ratio of the volume change and the pressure change. What that means is this: if I draw a graph where I say this is the pressure changing, and what pressure we are talking about, the transpulmonary pressure. It is also called transmural pressure. This is the pressure that is the difference between the pleural pressure and alveolar pressure. Remember, in our discussion we had drawn, let's say this is the one alveolus that is representing the lung, and then we had this space here. This space was representing, this space is representing the pleura, and we know that the parietal pleura, the outer surface of the lungs or the pleural cavity, is pulled outwards by diaphragm on the lower side, and of course by the ribs and the chest cage from the sides. It is connected with them. So we have done this discussion multiple times before. So what happens is this parietal pleura is pulled outwards by the rib cages and outward by the diaphragm. However, the visceral pleura that is connected to the internal pleural layer connected to the lungs is actually adherent to the lung tissue, and because lungs tend to recoil, and we have done that as a separate lecture, lungs like to collapse, they like to recoil. So there is an inward force of the lungs recoil, there is an outward force because of the pull on the pleura. So inside the pleura the pressure is normally negative. Let's say at rest it is -5 centimeter of water. That is the normal pressure there. We also know that the pressure in the alveoli at rest is about 0 centimeter of water. This is the atmospheric pressure. That is, if I exhale and I stop and keep my epiglottis open, then the atmospheric pressure is the same as in the alveolus. So that 760 millimeter of mercury pressure is the same as 0 centimeter of alveolar pressure, or the atmospheric pressure inside the alveoli is we take the water pressure, and that is 0 centimeter of water. The difference between these two pressures is called the transpulmonary pressure, or it is a pressure that is transmitted through the lung tissue and is applied to the alveoli or the air inside the alveoli. So what is that pressure? If I make that here, down here, what we'll see is normally if the alveolar pressure is at 0 centimeter of water and the pleural pressure is at -5 centimeters of water, then you subtract them, and that is the transpulmonary pressure, pulmonary pressure or transmural pressure. So that is the pressure we're talking about. As this pressure changes, we need to understand what happens to the lungs and the chest wall. So first of all, let's take this alveolus, or let's say this is a lung. And even before that, going to my favorite grapes over here. So look, imagine this is the airway. Airway comes in and bifurcates. This is not a good example of the airways because the branches here are many. In case of the airway, the branches are always 2 from each one branch. So that is a binary fashion in which the lungs divide. Now the alveoli are connected at the end, and this again is not the accurate example of the alveoli because alveoli actually open up into a sac that is connected to the last part of the terminal or respiratory bronchiole. So what happens is that the last part of the respiratory bronchiole dilates into a sac-like structure, that is the alveolar sac, and from there alveoli are connected, right? So this is the alveolus, this is another alveolus, and so on, and there are more. So this is the structure. Now what we're talking about is, if we take a lung, this one alveolus or one lung is going to represent all the alveoli. If we take a lung and take it out of the chest cavity and put it somewhere, what do you think inside it, what is the pressure? 0. There is no pressure. The air inside does not feel any pressure. So that is the 0 pressure. So if the pressure, this is the pressure and this is volume, at this moment lung is fully collapsed. Lungs like to collapse, they like to shrink. So what happens is, when the lungs are taken out of the chest wall, in the chest wall they are by force expanded. They are taken out of the chest wall and they would shrink and collapse. So when these are collapsed, what is the volume of the lung at that time? Almost, let's say, 0. So this is the volume, let's call it almost 0. The pressure is 0 as well, 0 centimeter of water. So that is the situation of the lung. Now from here, this point, this is this point. Pressure 0, volume 0, or volume almost 0, pressure 0, for example. Now if we started reducing pressure outside of it, if we started inflating it, I can't reduce pressure outside of it to inflate it, so I'm just going to do positive pressure here, and that is I'm going to blow into it like that. So what happens is that as the pressure increases, so let's say -2 centimeter of water, then -4, -6, -8, and so on. As the pressure increases, what will happen? Lungs will fill up. So one thing that I want to tell you, in the beginning it was difficult to blow air into it, in the beginning when it was fully collapsed. Then when it started inflating, it was easy to blow air into it, and then at some point it's going to become fully inflated and you can't really inflate it further, right? So you have experienced this as well. So what happens is that as the lungs are shrunken and you increase the pressure, the lung volume starts increasing. So let's say the volume starts going up like this. And what happens is, at some point when the lungs are fully inflated, then the pressure, the volume change starts becoming less for the pressure change. This is the process during the inspiration. So if these lungs were installed inside the chest cavity and we were expanding the chest cavity and we wanted to inhale, inspire, this is the curve that would appear. The only difference is that when the lungs are present outside, they start at a volume of 0. When they are present inside, there is going to be a residual volume. There is going to be a small volume that can never be removed from the lungs. Remember residual volume, we talked about it. That is this residual volume. Okay? When we allow the lungs to deflate, so if I inflate this, now if I allow it to deflate, what will happen is that lungs will deflate not in the same path again. Instead, they deflate like this. So their deflation curve, this is the expiration, this is inspiration. The deflation or expiration curve, where the volume changes with the pressure, is different from the inspiration. This difference in the curves is called the hysteresis, pulmonary pressure volume loop hysteresis. However, just keep this in mind that this is a lung that is present outside of the chest wall. Now let's look at the chest wall itself. What is the property? What are the properties of the chest wall? So for the chest wall, what I'm going to do is this. I'm going to take a chest wall. So here it is. So this is a chest wall of a person whose neck area is separated and we have closed it. We have not allowed the chest to fully spring open. If the chest is fully cut down, it would spring open. However, the recti, rectus abdominis, and the obliques are pulling it downwards and keeping it closed. Similarly, the thoracic cavity and the muscles here are also keeping it to somewhat extent expanded but not fully expanded. Then the rib angles are such that chest is not fully expanded yet. So if you sever it from the muscles, then chest will open up. So this chest is not open. However, it is closed and lungs are removed. Lungs were removed and put here to see this. Now, because chest is not fully inflated, if you attach a meter here that shows you the pressure, and let's say this side is minus and this side is positive and this is 0, then the pressure is going to show on the negative side. Why? Because chest wall is trying to expand, that is its natural tendency, but the air cannot go in, so there is subatmospheric pressure in here. Okay, now let's say we also add a pump to this system. Here is a pump through which we can either send the air in or we can pull the air out. So let's see now what happens to the chest wall. So if I draw the chest wall graph over here, once again one side is pressure and the other is the volume. Let's say this is the 0 centimeter of water. First question, do you think, so let me draw 0 here, volume. Do you think that the chest wall can ever be brought down to 0 volume? So if I take this as the representation of the chest wall, if I try to suck all the air out of it, do you think that it can ever be brought down to 0 volume? That means inside the chest wall there is no lumen, there is no cavity left, the whole thing is collapsed. Can that ever happen? No, that will never happen if for a normal chest. You took a tractor trailer and you run that over the chest, yes, it is going to become mushed and stopped. and it is going to become zero volume. However, a normal chest will never go to the zero volume because there are ribs attached here, and ribs are not going to collapse down to zero volume. So what will happen is, if you started sucking air out of the, so let's say this is the air, and you turn the pump on, you start pulling the air out, right? So this is the air is going out. What do you think will happen to the volume as you pull the air out? Chest wall is going to start shrinking, right? It is going to start shrinking. So volume will start reducing as you pull the air out. So let me make the volume in red, in blue. It would start reducing. But this volume can never reach zero. It would always stay some number above. This is the minimum you can do. And that is why even when in normal person, when you ask them to exhale forcefully and as much as they can, there is a point after which they, even if they continue, they can't exhale anymore, and there is still air in the lungs. That is the residual pressure. That is the residual volume. That is because chest cannot deflate any further, right? So this is the point of the residual volume, right? Now, if you start inflating it, remember this is not the alveolus, this is the chest wall. Inflating it or inflating it, how big can the chest wall go? Can it burst open? No, there is a limit for how much the chest wall will open up, again because of the bony rib cage, because of the muscles, because of the whole structure. It's not just going to keep expanding in its volume forever. So that means if you make the pressure changes, it would go up and up and up like this. This is its limit. It cannot expand any further. It cannot increase the volume any further. So this is about it. Now you can exert whatever pressure you want. It has reached its maximum. So this is the graph for a chest wall. This is the graph for a lung. Now important thing here is this, the slope of this graph. The slope means what is here? Pressure. What is here on the y-axis? Volume. The slope is here. This slope is the compliance. What does that mean? That means, look, let me fill the same lung with water. What that means is take the lung out and fill it fully with water. Now what will happen? Let's draw that over here. So this is the lungs with water. So again, pressure and volume. This is zero. Do you know that if the lungs are filled with water, normally at -2 centimeter of water, they become fully filled, and then by -1 centimeter, -3 centimeter, they become fully emptied. So if they're filled with water, 2/3 of the recoil is gone. That 2/3 of the recoil was because of the air fluid interface. We did a separate lecture about it. That causes it to collapse. Now when the water is filled in, you pump some more water, lungs just open up very fast. You take the water out, lungs collapse very fast. So they become more compliant. They're easy to fill and easy to empty. So that is what happens when there is no air fluid interface. However, when there is interface present, then this is what happens, and you know it that if we combine these two now, before that, how about the slope here? See the slope, pressure, volume, pressure, you make a tiny pressure change. I hope you can see it. Very tiny pressure change, and you have a huge volume change. Huge volume change from here to here. Tiny pressure change. If you see here, the pressure change to do the similar volume change is going to be a lot. Somewhere like this. Make sense? So the thing is this, that the pressure, the slope of the compliance graph tells you how easy it is for the lung to fill or not. Imagine now if I made another graph here, let's make that here. If I made another graph in which what I did was I showed the slope like this. Now what's happening is that for a particular, let's say I have to have this type of a volume change. That means from here to here or somewhere over here, this is the volume change that I want, the same volume change. But look at the pressure change that I need to do. I have to go from 1 unit, 2 unit, 3 units, 4 unit, about 4.5 unit. So about 4.5 centimeter of water change to only cause the same volume change as I did here. What is wrong with this slope? This slope is saying that the volume and pressure change, pressure and volume change is, volume change per pressure change is now less. This is a less compliant lung. This is a very much compliant lung, right? So I hope that you understand in the exam how to look at the slope and be able to tell is it compliant or not compliant. Okay. Now let's do one more thing. This can also be in the exam, and that is that you combine this graph and this graph. That is the lung and chest cavity combined graph. So I'm going to make that over here. So pressure, volume, 0. We know that the chest cavity's graph looks like this. We also know the lung alone graph looks something like this. Now if you combine these two, that is, you install the lungs inside the chest cavity, you put the lungs in the chest cavity, you install that, you make a proper chest cavity which is trying to move out and the lung is trying to recoil and collapse. Then what happens is, somewhere in the middle, these two opposing forces become equal. Chest moving outward and recoil moving inwards. These two opposing forces, they become equal. So then what happens? We are at a stable, steady state. What does that mean? Look at me. I'll exhale and I'll stop. Now my epiglottis is open, the airway is open. Air is neither moving out nor moving in. Chest is not moving as well. This is a steady state. The outward movement, outward springing of the chest is balanced by inward recoil of the lungs. And there is some volume present in the chest, in the lungs at this time. That volume is a combination of residual volume, right, plus expiratory reserve volume, or it is called FRC. FRC, functional residual capacity. We have done that in our lecture before. This is that point, FRC. Now, what is the lungs behavior here? So let me make that diagram over here. Actually, so this is the combined chart. What are the properties of this combined graph? Number one, it starts from the minimum volume that chest can offer. Lung cannot collapse more in normal situation, more than as much as the chest can allow it to collapse. Well, if there is pneumothorax, then the lung would collapse because lung become disconnected from the chest. However, because lung cannot become any smaller volume than the chest cavity allows, we start from here. Secondly, the slope. Here the slope and here the slope is steeper. More change per volume, per pressure change. However, this is less steeper slope for the combined graph. This is the graph that you are used to. What does that say? That says -2 centimeter, -4, -6, -8, remember? And we had done this at -5 centimeter of water. From -5, when we go to, let's say, -8 centimeter of water, This is the process of inhalation. What happens? That the pleural pressure is increased from -5 to about -7.5 to 8, about 3 centimeter water change. And how much volume change appears for that 3 centimeter water change? How much volume change? Can you tell that? What is the volume change? Tidal volume, right? Tidal volume, VT. What is the amount of that? 5 to 600 milliliters. I'm going to use 600. So over here for 3 centimeter, and now this is the USMLE question, for 3 centimeter water change, you have 6 milliliter tidal volume moving in. What do you think for 1 centimeter water change? 1 centimeter water change, water pressure change, 600 milliliter divided by 3 equals 200 milliliter of the volume, or you can also say that the compliance of this lung equals 200 milliliter of the volume change per 1 centimeter of the water pressure, centimeter of water pressure. That is a compliance. What does that mean? That simply means this, guys. Small change in the intrapleural pressure would allow a decent amount of air to go in or come out. That is the tidal breathing. Small changes, 2 to 3 centimeter water changes. However, now if this becomes abnormal, if this process becomes abnormal, for example, emphysema. Emphysema is a situation where the alveoli come here. These alveoli, remember, these alveoli are trying to pull the lungs inwards, right? They're trying to collapse the lung, so that is a recoil force. These alveoli start getting damaged. The most common cause of the emphysema, for example, is smoking. So smoking caused damage and scarring and fibrosis, and the alveoli are now becoming damaged and they are ruptured and they are opening up, right? So that would be, if I take this and some of these guys are all broken up and they are all damaged, so that is the alveoli that are damaged. Now what would happen with these damaged alveoli? Do you think if you push some air in it, it would work? Do you think it would have a recoil? These are actually collapsing alveoli. These are the alveoli that are damaged. So their function to recoil is reduced. When the recoil is reduced, what would happen? Guys, this is really important. If the lung recoil is reduced because of emphysema, collapsing alveoli, damaged alveoli, not collapsing, that is atelectasis, emphysema, damaged alveoli, they are bursting open. What would happen to the lung? Recoil is reduced. Now chest is trying to move outwards. Do you think chest will move outward? Now yes, because the recoil force has become reduced. That reduction would allow the chest to move out, and chest moving out will cause some more air to go in. That more air going in will increase the functional residual capacity, right? And now the patient has more air in the lung, and that is what has happened. The lungs compliance has become easier. So that is emphysema. In emphysema, if I draw that here, let's say this is the pressure, this is the volume, and let's say this was a normal change, normal lung volume change for pressure changes. As the pressure changes, lung volume changes. With the emphysema, it will become easy to change. So you change the pressure a little bit, the alveoli are damaged, they would easily open up. So the volume change for small pressure change will be now from here to here. So this is a lots of volume change compared to normal state from here to here is less volume change. So that is the outcome of emphysema. Most common cause, smoking. How about the other side of it, the restrictive side of it, where fibrosis occurs? For example, the lung is damaged and scarred by continuous infections, or there is systemic sclerosis or SLEs or other immunological diseases, or there is asthma, or there are other local irritants. that are causing damage to the lungs, and lungs are becoming scarred. In these scarred lungs, the recoil has become increased. The lung has becomes fibrosed. Remember, the scars shrink. So when the scar is going to shrink, it is going to pull lung inward. So recoil increases. So what would happen to the chest cavity? That would also be pulled inwards. So lung and chest cavity both will now be recoiled a little bit, deflated a little bit. So what would happen to the functional residual capacity? Will it still be the same? No, the lung volume has reduced, so the residual capacity is reduced. Now what will happen if you try to inflate this lung? If you're trying to move the pressure needle so that you can increase the volume, do you think that it would be easier? No, it is going to become difficult. So now this is fibrosis. What happened in this case? That you have to really increase pressure a lot to make this much change in volume, which is really very tiny amount of change. If you see on the normal curve, if you make the pressure change from here to here, look at the volume change. How much volume has changed? If you look at the hypercompliant lung, if you go from here to here, the lung is totally expanded or probably even burst. So this is emphysema where the alveoli are getting damaged and they're easy to open. I want to continue saying it. In the beginning I said that they are recoiling and they are collapsing. That was atelectasis. This is the emphysema where the alveoli are damaged and they are opening up, and it's easy to open them up. They are flailing and they're burst and their walls are damaged, so it's easy to just open them up. This happens with the age as well. For example, look, you may have done this, that sometimes when the balloon is difficult to inflate, what do? If it is difficult to inflate, you do this, right? And what does that do? That breaks the elastic fibers in the balloon or lungs, and finally it becomes easy, it becomes more compliant to inflate it. Same is the case with the aging. As we age and we continue to inhale and exhale, we keep breaking those fibrous bands slightly with every respiration cycle. And so slowly the alveoli and lung become more and more compliant. So it automatically happens with age as well. So anyway, so that is the situation with the fibrosis and the emphysema. This is the lung compliance and its formula. Thank you.